Sanjaya, thank you for the invitation. It's very nice to see some familiar names on the Zoom list, and welcome to all of those from India attending the. I understand there's a meeting going on, so thank you for attending and welcome. I thought to give such a talk on rejection because a lot of what is rooted in what we do post-liver transplant for rejection is very old, and there's not a lot of really good new literature on this, and I think that this is a sort of a ripe area to do research for anybody, especially fellows in training. So to just summarize, as many of you who deal with liver transplant patients know, these are the mechanisms of rejection, and the typical medicine we use, the stalwart medicine of the CNIs, the calcineurin inhibitors, Prograf, cyclosporin, and these are the areas within the cell cycle that our rejection medications work. You see the mTOR inhibitors here, and when we have severe rejection or with the use of induction, we use ATG and thymoglobulin. Now, the classic teaching, when I was training at least, was that liver rejection did not impact mortality as it can after renal transplantation. But recently, I think those victims have been sort of questioned, and Josh Levitsky published in 2016, I think a very thought-provoking article looking at the A2all, which is a live donor database within the United States, and the SRTR, which is the clearinghouse of liver transplant data. And he actually found that the development of T-cell mediated rejection worsens patient and graft survival at all points post liver transplant, even when it occurs early. So as you can see here, that rejection in the live donors increased mortality 8-fold, graft failure over 6-fold, and in the SRTR it does the same, although not as pronounced. So rejection can make a difference in the lives of our patients, and that's why we have to be very vigilant in treating it and in preventing it. So one of the concepts I wanted to stress here, and something that I've learned, over the last couple of years, is the difference between your typical T-cell mediated rejection and late T-cell mediated rejection. So late T-cell mediated rejection is defined as occurring more than 6 months post-transplant. And unequivocally, this has a worse prognosis than when rejection occurs in the first several months after transplant, when it's at its highest risk. Thankfully, late T-cell mediated rejection only affects a minority of liver transplant recipients. The thing to remember here is that there is a decreased response rate to initial treatment with steroids, and steroid-resistant rejection is much more common in this entity. Now, I think where some of the dilemma lies in the management of these patients is that the histology may be atypical, and that may delay the diagnosis. So these are very, very complicated liver biopsies to interpret, because also sometimes more than one thing can occur simultaneously. So the histology of a late T-cell mediated rejection is atypical. You will see plasma cells, interface hepatitis, piecemeal necrosis, and centrilobular and perivenular inflammation. These are the sort of the buzzwords for the clinician that you should be aware of when the pathologist comes back to you with the interpretation. So as compared to a typical T-cell mediated rejection, the inflammatory infiltrate is more lymphocytic, whereas in your typical rejection, you have eosinophils, some plasma cells as well. And there's less vascular and bile duct injury. We're going to touch on the typical features of rejection in just a moment. So I want to, again, stress these histologic findings in these late T-cell mediated rejection biopsies to help you recognize them, that this may be a different entity that needs more aggressive treatment. Most cases of idiopathic hepatitis that occurs post-liver transplant should be considered as cases of late T-cell mediated rejection, and there's clear decreased 10-year survival in comparison to people who were developing your typical early rejection. This is, although it's 10 years old now, this is from a study from the UK, from King's College, looking at late acute cellular mediated rejection. And it was more common in PBC. And again, the concept is that people who have autoimmune related liver disease, PBC, PSC, autoimmune, may have a slightly higher risk for developing this. So if you look at the late rejection cases, a good number of them had PBC, PSC, and you look at the timing, where the mean is almost a year and a half after the transplant. And when compared to patients who had rejection who didn't have the late onset, you could see here that there was also a history of rejection. So these people were rejecting early on, and there was a much higher rate of losing the graft. So one thing to take home from the talk is late acute cellular rejection is a different entity that we have to be on the lookout for. I alluded to the typical rejection activity index as how we assess liver biopsies. And I think all of you who take care of post-liver transplant patients are acquainted with this. You could see that this consensus document from the Banff meeting is from 1997, but this is time-tested, and you can see it involves degrees of portal inflammation, bile duct inflammation, endothelial inflammation. So these two components may not be as involved in late T-cell mediated rejections. You look at the severity of the rejection, and this is what our liver pathologists tell us when we review the biopsies with them. You can see that each variable is given a score of 1 to 3, and at the end, your cumulative index tells you how severe the rejection is. Now, sometimes does it really make a difference knowing what the severity of the rejection is? And it seems that the histology may not correlate actually with long-term clinical outcome. Again, in another big study from the UK, where they looked at over 230 patients who had early rejection, there was no statistically significant relationship between the severity of rejection and death, graft failure, retransplant, or the development of chronic rejection. In that Levitsky study, they also showed no impact of the histologic severity of rejection on the long-term patient outcomes. Now, intuitively, one might think that severe rejection might be more of an issue, but I think a lot of it boils down to how you treat the rejection, how you're talking with your pathologist and sort of understanding if there's more than one thing present on the biopsy. So I think a lot of this is center-specific effect on these outcomes. So how do you manage T-cell mediated rejection? Well, mild rejection, we optimize the Prograf level. If someone's on cyclosporin, we may consider switching them over. We optimize the level, and we either increase or add back the mycophenolic acid or mycophenolate. When people have moderate or severe rejection, at our place, we give them steroids. We give them 500 milligrams of methylprednisolone for 2 to 3 days. Now, if you look at the literature critically, there's not a lot of data to guide us here. And there are different regimens. And if you look at the comparison of these two regimens, and I would call to your attention this publication here, which I would encourage you to read. there's really no difference in infection risk and efficacy between these two groups of patients, including this group where patients received less parenteral steroids. So parenteral steroids, you have to be a little bit careful with. I've seen several episodes of severe pancreatitis and obviously the risk of infection. So don't really go too aggressive with the parenteral steroids because there's not a lot of known literature on their efficacy. Now, 60 to 80% of people will respond to a first course of parenteral steroids, and usually you see the biochemical improvement within the first couple of days, and typically it's pretty pretty impressive decrease in your aminotransferases. Now, remember, the bilirubin is going to take some time to decrease. 5 to 10% of people who do not respond to the initial course of high-dose steroids will respond to a redosing. So not a large number of patients bear this in mind. So steroid-resistant rejection may occur in up to 10% of patients developing rejection. We kind of think that this is less problematic in the DAA era because we don't have to deal with the confounder of hepatitis C and worrying about the hepatitis C is going to flare on modulated immunosuppression. Here at Mount Sinai, we often repeat a biopsy to make sure that there's nothing else going on or that the histology hasn't changed. What's become standard of care at our place, and I think in many liver transplant centers, is to assess donor-specific antibody to see if there's a chance that this is an antibody-mediated rejection. So in steroid-resistant rejection, we infrequently, but sometimes do fall back on thymoglobulin and ATG. And you could see that in these studies, again, somewhat old, patients do respond, but at what risk? You know, here, one patient developed fungal infection out of 11 3 CMV. A good number of people respond histologically and biochemically, but we have to be careful at what cost. In this series, 4 patients died, 3 of infection and 1 of multisystem organ failure. We were talking about infection. These are complicating factors of rejection therapy. This is your classic example of a CMV hepatitis. Remember to restart the prophylaxis in these patients when giving high-dose steroids. If the liver tests are declining and then abruptly increase, consider complicating factors like viral hepatitis, a new infection, a bile duct problem, which is not always very cut and dry to diagnose, and a drug-induced liver injury. And very often renal dysfunction and side effects of the immunosuppression therapy occur and make it somewhat more difficult to treat the rejection. So a proposed regimen for people who have repeated episodes of acute cellular rejection, we'll try to tailor the immunosuppression. As I mentioned, patients having autoimmune liver disease have higher rates of rejection. I think a key here is that both the clinician and the patient have to be aware of the ongoing risk of rejection and recurrent rejection. So this is a patient that has to sort of be identified, needs more maybe rigorous and vigilant follow-up. Regular assessment of CMV and EBV PCR, trying to monitor the levels of the immunosuppressants as much as possible. Periodic assessment for donor-specific antibody, or for people who were transplanted 20 years ago before we started doing DSA, at least HLA antibodies, and getting a protocol biopsy. Infrequently, we end up using maintenance steroids in patients. We can give them budesonide. And then I think another thing I want you to leave this talk with is the consideration of the possibility of antibody-mediated rejection in patients who have repeated episodes of acute cellular rejection or severe rejection. So some of the clinical tips that I think are important to follow. identify the precipitating reason. Why did this happen? Well, did the patient not take their medication for 3 or 5 days? Were they having a diarrheal illness that decreased their absorption of the tacrolimus? Or is this something that sort of popped out of the blue and makes you think that there's something else going on? So I think identifying the precipitating reason is important. Follow the labs frequently. I think when we have someone in the hospital that we're treating for rejection, we sort of want to get them out of the hospital as much as possible. But I think sometimes we send them home early before really they have a very good prograph level. And they're doing well, and then they go home, they come back a week later, and their numbers are very abnormal again. The benefits of the therapy may take an extended period of time. If people have an elevated bilirubin, it's not going to normalize overnight. Consider frequently reassessing the histology on the biopsy. How much acute component versus a chronic component is present? What is the severity of a chronic rejection? Is there evidence of more severe damage? Again, central lobular necrosis, a lot of plasma cells. These are bad players that we have to be careful about. As I mentioned, consider the confounders. We've had people who've developed HLH, who've had hepatitis E. We had one patient develop IgG4 disease. So these are not common, but these are something you have to think about. Educating the patient, very important. Vigilance with the medications and follow-up. And if people lose their graft because of rejection, it doesn't mean that the same thing is going to happen after a retransplant. So I think retransplant should be considered as an option. So I alluded to chronic rejection, and chronic rejection, thankfully, is seen less these days because we've developed a lot of facility with using our immunosuppression. So as many of you know, it's associated with bile duct loss and foam cell arteriopathy, and this is a common finding in both renal transplant and heart transplant in people who developed chronic transplant rejection. Now, the thing to remember here that in late chronic rejection, you see all of the typical findings, the loss of bile ducts, the foam cell arteriopathy. However, early on, you may not see it. You may have only an occasional bile duct loss. So you have to be very, very careful. And you can have necrosis, you can have inflammation. So these, again, are buzzwords that we should remember. Is this someone who is developing an early chronic rejection that we have to be more aggressive with treating them from the start? So again, not every early chronic rejection is going to have your typical findings. So how do you manage chronic rejection? Well, there's little role for steroids when there's not a lot of inflammatory infiltrate. So the focus is on maximizing your CNI. Again, if someone is on cyclosporin, we switch them to Prograf if possible. We run their Prograf level a little bit higher. We add back Cellcept, for instance, and or sirolimus, just to give them a little bit of a boost, even though there's no data, frankly, to support this. Very often patients have concurrent renal dysfunction, which may complicate running Prograf levels a little bit higher. Very often the patient can have pruritus, so we start ursodiol. I think there's very little downside to it. Whether there's some additional immunologic benefit to it, I'm not sure, but again, no downside to doing it. And people who have appreciable chronic rejection, we consider relisting for retransplant. So some of the poor prognostic factors for chronic rejection for death or need for retransplant include more severe bile duct loss, a higher total serum bilirubin, as a fellow, I remember being taught that, well, if your bilirubin is above 10 with chronic rejection, you're not going to get better. I'm not sure I still hold that true. I've seen patients recover from much higher bilirubins, but I think that it is indeed a prognostic factor. I think that if people had hepatitis C that was active, you can imagine that they would do worse because their hepatitis C may progress as we're trying to optimize the immunosuppression. So I'm not so sure that this is going to be the same in the post-DAA era. Patients often die with chronic rejection, not of chronic rejection. So what this means is that we try to salvage the graft, and we keep increasing the immunosuppression in the patients develop renal failure and infection, and then we lose them to infection. So I think we just have to think about this when we're treating someone. The problem is, though, when do you cut bait and run? When do you say, okay, enough of the immunosuppression, we're going to retransplant this individual? And for fellows in training, there's really no recent data on the pathophysiology and treatment of chronic rejection. It's a good area of study. So I'd like to segue to plasma cell rich rejection, which is the new accepted term for this entity, which is in the past was referred to de novo autoimmune hepatitis, immune-mediated hepatitis, alloimmune hepatitis, or plasma cell hepatitis. I mean, clearly this entity is a variant of rejection with increasing evidence that it is likely antibody-mediated rejection. We initially saw this, and all centers saw this in people who were getting interferon-based therapy for recurrent hepatitis C. And once they developed this, they had a very, very poor prognosis. The plasma cell rich rejection may be seen in the same setting as chronic rejection or severe T-cell mediated rejection. So again, these biopsies are very, very complicated. There's also, I think, another natural history where patients can have this and they have a slow smoldering course that ultimately leads to allograft loss after years. And that's why we consider doing protocol liver biopsies in certain patients and doing fibroscans. So the treatment with this is optimization of your Prograf, your azathioprine, or Cellcept, and usually maintenance steroids. But the issue is that these patients may be somewhat refractory to medical therapies. So the plasma cell rich rejection really looks very similar to your severe autoimmune hepatitis, and the liver pathologist really can't tell the difference. It looks the same. Again, a very interesting and good area to study. So you have all of your typical findings and post-transplant findings of necrosis and collapse, very bad. So these are patients that need aggressive therapy. Here again, you may see central perivenulitis, another buzzword for a bad case of rejection. A good number of these patients have donor-specific antibody, making us think that it is antibody-mediated rejection, and there is C4D staining on the biopsy that is part of the diagnostic criteria for AMR. I've alluded to donor-specific antibody. This is sort of a hot topic in the liver transplant community. I think clearly, you have class 1 and class 2. Clearly, some patients have very high donor-specific antibody are going to be at risk of rejection and graft loss. Now, it's not that simple because you do have people who can have very high DSA that come down and they never run into a problem. So different centers have different philosophies with regard the use of DSAs. Now, remember that the liver is very immunotolerant. So, for instance, people who get a kidney transplant with a liver transplant may reject their kidney a little bit less. And so for for SLKs, for simultaneous liver kidney transplants, we get these DSAs because our nephrologists want them, and sometimes they're very scary elevated, but patients seem to do well. So at our place, we are not routinely ordering DSAs in people going into transplant. However, if they reject by protocol, we're getting them, and then we get follow-up levels, or if people require a retransplant for one reason or another. I alluded to antibody-mediated rejection. There are a myriad of histologic findings that one would see, and what's bolded here, again, buzzwords: microvasculitis, capillaritis. These are the things that one should look for with acute antibody-mediated rejection. To meet the criteria, you have to have C4D on liver biopsy, elevated DSA, and a requisite histology. There's also a chronic AMR or a late onset acute AMR. Again, these are not strongly defined yet in the literature, but these can be causes of allograft failure, the development of ascites post-liver transplant, the development of portal hypertension. So again, similar type of features that are necessary. And these are patients that may have portal fibrosis. You don't know why. They haven't had viral hepatitis. So portal fibrosis is the buzzword here. Obliterative portal venopathy, nodular regenerative hyperplasia, things that we see as causes of non-cirrhotic portal hypertension in the non-transplant recipient. These may be features of antibody-mediated rejection in the liver transplant recipient. There are several associated histopathologies that you may see with AMR. As we mentioned, steroid resistance, plasma cell-rich rejection. People who have idiopathic biliary abnormalities, idiopathic fibrosis. You have to think about these things. And remember that any type of biliary or vascular thrombotic abnormality may be part of immunologic dysfunction. So if you have people who have some bile duct, intrahepatic bile duct strictures that they're not technical related, are they ischemic, or could they be rejection? Remember that if you transplant someone with ABO incompatibility, they will develop severe biliary abnormalities after transplant, changes of ischemic cholangiopathy. So clearly there's precedent for some of these biliary injuries being immunologically mediated. When to suspect acute antibody-mediated rejection, thankfully it's common, but the classic teaching was that this never occurred in liver transplant recipients. I don't think that that's the case. I think it probably occurs more than we think. And these are very often in people who have very high DSA levels. And the other thing to remember is that when you have antibody-mediated rejection, it's not clear-cut on a biopsy. It can be a very difficult diagnosis to make, and you may have features of it concurrently with T-cell-mediated rejection, plasma cell-rich rejection. The management is the difficult thing. So we look to try to treat the acute T-cell-mediated component as much as possible. So a lot of these people get steroids. They get higher doses of CellCept and Prograf. And we have a patient now in the hospital with what we think is AMR. We've given him thymoglobulin. He failed thymoglobulin, but then we placed him on plasmapheresis and IVIG, and he is improving somewhat. So our protocol, and this is a protocol similar to the what our renal transplant colleagues use, is followed by rituximab. And then the key is to follow these people long-term. Again, they're not going to get better, in a couple of days. It's going to be weeks to months. So you just have to be on top of them all throughout this time. There is some data on the use of bortezomib, mostly in the renal transplant literature. We have not used this here. Remember, this does have some intrinsic hepatotoxicity. So there's not a lot of data, strong data to support this, nor belatacept to treat AMR. So I wanted to segue to a topic associated with rejection, and which we're seeing a lot more of these days. And this is with the use of ICIs, the immune checkpoint inhibitors, for management of HCC. So the ICIs have very complex immunologic effects, and to suffice it to say that they disrupt the equilibrium of immunologic tolerance. So people are at risk of rejection with the use of the immune checkpoint inhibitors. And as time goes on, there's more data coming out about them. More and more centers are using them. So this is, I think, a key point that liver transplant centers have to remember. Now, when I told a renal transplant colleague that I was thinking about using an immune checkpoint inhibitor post-transplant, she looked at me aghast, like a look of horror came on her face, because the data in the kidney transplant literature is not very good. So the use of the immune checkpoint inhibitors post-kidney transplant, patients have very high rejection rates. This is the treatment of choice for melanoma and squamous cell cancer and other neoplasms. So when rejection occurs in these patients, it can lead to allograft failure in upwards of 30% of cases. So I think the key here is that the previous strategy has been in parallel to lower the immunosuppression with the use of the ICIs. And I think this may be the teaching point here in the era that we have to reassess. The other important point here is that when rejection occurs with the use of immune checkpoint inhibitors, it's usually within 3 to 4 weeks at the beginning. So this is the time that rejection occurs, and patients don't do well. There's a very high mortality rate in this population, but I think in some regard it's because the treatment is now salvage therapy. So patients may have a worse functional status, and a lot of them die of progressive neoplasm because this is sort of the last-ditch effort that we're using for them. So there was a systematic review of ICI use in solid organ transplant recipients. They looked at 119 cases, and 75% of them received PD-1 inhibitors, the rest CTLA-4 inhibitors. And in this group, 22.7% of cases were HCC. So in keying in on the liver transplant recipients, rejection occurred in 30% of the liver transplant patients, 30%, and graft failure in 21%. So this is a real phenomenon and a concern for us. Again, the median time to rejection was 3 weeks. So this is the key here. Now, soberingly, the objective tumor response overall in all of these patients was 35%, was lower in HCC. The most common cause of death was progressive malignancy, followed by graft failure. So these patients are sort of end stage. They've tried and failed everything. So the last-ditch effort is putting them on immune checkpoint inhibitors. What they found was that rejection probability decreased with an increase in the number of immunosuppressants the patients received, and there was a higher risk of acute rejection in patients who had a previous episode of rejection. I've managed now over the last year and a half 2 patients who needed an immune checkpoint inhibitor for melanoma, and I think we successfully managed them. They didn't develop rejection because we actually went up on their immunosuppression instead of decreased it. I mean, unfortunately, they succumbed to the melanoma, but they didn't reject. So I think this may be something that we can learn from and maybe try in selected patients. So overall, immunotherapy is creating challenges for reduction and maintenance immunosuppression. I think the pre-transplant use is somewhat less problematic, but rejection can be more severe post-transplant. There have been reports of people who received pre-transplant immune checkpoint inhibitors and having severe rejection, losing grafts at 8 days and 5 weeks after their transplant. As mentioned, suboptimal immunosuppression may be playing a role, and I think what we do at our place is that we identify people who are on checkpoint inhibitors going into transplant, and then when they are transplanted, we're sort of more on top of them and understand that they may have a higher incidence of rejection. We do not change our induction regimen or transplant regimen, but we make the team aware that this is someone who may reject. So if you look at the published literature on case reports of neoadjuvant immunotherapy use, some of them, again, have very sobering results, and you can see, graft loss here. Now, one of the publications is from our place, from our surgical colleagues, and that we transplanted at this time 9 patients, and they had nivolumab use within 4 weeks of transplant. So these are high-risk patients. Remember, the half-life of some of these agents go up to 50 to 60 days. So in these patients, there was only 1 episode of rejection. And I think this is probably because at our place, we sort of tend to over-immunosuppress patients at the beginning. This number, I think, now is tripled. And again, we have only seen, I think, 1 or 2 additional cases of rejection because they are receiving higher upfront. Are these cases of antibody-mediated rejection that occur very early? I suspect that they could be. I've talked to people and they've said, well, maybe if someone has gotten the checkpoint inhibitor, 2 weeks before they get transplanted, maybe they should have plasmapheresis. I think it's something worth thinking about. So again, from my perspective, and looking into this, I think the checkpoint inhibitors, they have to be used with caution in the peri-transplant setting, but rejection, I think, can be prevented or successfully treated when you're using in the pre-transplant setting. I'm not sure that you need to change your protocol for these patients. We don't particularly limit patients if someone gets called for a transplant. I mean, if they received a checkpoint inhibitor 2 weeks ago, we're not going to not transplant them. We're going to proceed. If you had a live donor, for instance, maybe you want to try to back off the immunotherapy going into the transplant if you have that flexibility. I think we need a lot more data in this space, but I wouldn't be afraid to use the checkpoint inhibitors if it's felt to be the best option for the patient at that time. So finally, I wanted to talk about, sort of rejection and long-term maintenance of allograft health. Now that we've dealt with the issue of hepatitis C, I think as transplant hepatologists, we can focus more on, how can we extend the life of these grafts. We've been doing transplants here since 1988, and we're starting to see that, especially pediatric patients, are starting to come in with, needing another transplant. So are there things that we can maybe do to extend the life of the allograft? So we know that a large number of liver transplant recipients with normal liver tests can have abnormal liver histology, and a lot of this work comes out of the Barcelona group and King's College. And when they looked at some of these people, they were molecularly indistinguishable from acute cellular rejection on tissue biopsy. So this was a very interesting study, and I would encourage, this is a good study for a journal club. I think this is from the Journal of Hepatology in 2021. There was a cross-sectional study of 190 patients undergoing transplant who were participating in an immunosuppression withdrawal trial. Now, these were very selected patients. They were stable with normal liver tests, no autoimmune liver disease, and no active viral disease, and a lot of different studies were performed, including FibroScan and protocol biopsy. So interestingly, what they found was that, well, 64% had no or minimal allograft damage. So these people were okay to consider immunosuppression minimization. So these are well-selected patients, protocol biopsies. But the thing to be concerned about is that 35.8% of patients were considered unsuitable for immunosuppression minimization because they had moderate to severe portal inflammation, more than grade 2 fibrosis. So this is very sobering. And if you look at their ALT levels, if they had an ALT of less than 15, it was associated with extremely low likelihood of underlying damage histologically. Well, I don't know about you, but I think I have very few, if any, of my post-transplant patients have ALTs less than 15. So if they had ALTs of more than 34, there was a 45% chance for moderate to severe damage. Now, a FibroScan, LCM FibroScan, was useful in identifying subgroups of patients at high or low risk for damage only between ALT levels of 15 and 34. So FibroScan wasn't that helpful in this group, although in my personal practice, I use it a lot more. So what this tells me is that if you have someone who's out several years out from transplant and you want to try to taper their immunosuppression, you have to be very careful about doing so, because if someone has underlying inflammation that you're not picking up, and then you try to lower their tacrolimus dose, this is someone that may reject and someone who may develop antibody-mediated rejection. These are some of the histologic features that were seen with these protocol biopsies. And again, to me, it was very significant. If you see here that almost 60% of people who had, again, no autoimmune disease, no viral hepatitis, had inflammation underlying. Over here again, portal inflammation, interface hepatitis. 30% of people had interface hepatitis. Now, perivenulitis, buzzword for antibody-mediated rejection, almost 20% of them had this on an underlying liver biopsy. So be careful in weaning these people long term. I've taken in my practice to considering protocol liver biopsy, and by protocol doing FibroScans. Now, there's not a lot of data on the use of FibroScans in the post-liver transplant setting. I mean, obviously, it can assess the degree of steatosis and fibrosis, and I think that there is a role for this in the post-SVR Hep C patient to decide, do they have underlying advanced fibrosis that would necessitate HCC surveillance in the post-transplant setting. But we're using the FibroScan really to replace protocol biopsies. Now, remember that cholestasis causes increased stiffness. It's not only fibrosis, but cholestasis. So we've picked up several patients with chronic rejection by performing FibroScan. So I think it's something to consider as a part of an immunosuppression weaning protocol in long-term survivors in order to triage the need for a liver biopsy. Many people don't want to get a biopsy. If you do a FibroScan and it's abnormal, I think that really strengthens the resolve to do it. And I think that you have to be very careful in lowering the immunosuppression in some of these patients. Some people are going to definitely get away with it, but others, you have to be careful and at least get a FibroScan, if not a protocol liver biopsy in the appropriate setting. Just a brief word on donor-derived cell-free DNA. This is a type of biomarker or liquid biopsy. This is used a lot in the renal and cardiac transplant settings. Obviously, this is being used now to screen for HCC and other malignancies in the non-transplant setting. single nucleotide polymorphisms and really advanced bioinformatics are being used to differentiate recipient and donor-derived cell-free DNA. So the cell-free DNA is released after cellular injury or death, although there is some present at baseline. This is looking for an early sign of rejection before the ALT goes up. This is, again, more being used in the renal transplant and cardiac transplant setting. There was a very nice article from Northwestern. Again, I would encourage you to look at this, where they looked at cell-free DNA and liver transplant recipients. As a result of cell turnover, the liver continuously sheds some deceased donor cell-free DNA. It's not particular to a specific disease, but rises when the liver chemistry tests go up. So in our patients, in the absence of Hep C, an increase in donor-derived cell-free DNA may be more pertinent for allograft dysfunction. So in the Levitsky study, it showed that the proportion of donor-derived cell-free DNA increased steadily, starting before an elevation of liver chemistry test in people who had rejection, and decreased following resolution of a rejection. So stay tuned with this. Again, there are a lot of large multi-center studies looking at this. I'm not sure that this is the holy grail that we've been looking for to help us manage a rejection, but maybe this is going to sort of give us some additional help with trying to wean people earlier on, getting them off of higher doses of immunosuppression just with more confidence that they're not going to reject. And the use of this cell-free DNA is already sort of in use in kidney transplant, and I think is making a difference. This is the Admiral study, a multi-center study of over 1,000 kidney transplant recipients, and they found that elevation of plasma-derived donor cell-free DNA was significantly correlated with clinical and subclinical rejection. So high levels were also associated with a threefold increase in DSA, again, a risk factor for rejection. So persistently elevated levels of this cell-free DNA predicted a 25% decline in estimated GFR over 3 years. So the conclusion here was that regular monitoring of cell-free DNA allowed early identification of clinically important renal allograft injury, and the biomarker monitoring complemented the histology and traditional lab surveillance strategies as a prognostic marker. The corollary is that persistently low levels of cell-free DNA might accurately identify allograft quiescence or absence of injury, and allow the clinician to maybe lower the immunosuppression a little bit more aggressively. So again, stay tuned with this. So in summary, although overall rejection rates have decreased appreciably over time in the liver transplant setting, to where rejection rates are well under the order of 10% at the majority of liver transplant centers, rejection still remains a cause of morbidity and a need for retransplantation at times. So early identification of high-risk patients may be helpful in preventing severe cases. Now, remember that antigen-dependent immune responses can trigger rejection. So we've seen people who are doing well over the years. So we are maintaining them on low levels of program, but then something happens to them, and then they develop a viral infection and they reject. We saw that not too long ago with someone who developed varicella, and they developed severe rejection in that setting. Histopathology is really important in the decision-making process for the diagnosis and management of rejection. Increased awareness of late T-cell mediated rejection and the possibility of AMR, I think, is really important these days. A lot more studies need to be done for looking at the treatment of chronic rejection, plasma cell-rich rejection, and AMR, and ongoing research in the promotion of tolerance and the prevention of allograft illness and maintaining allograft health remain crucial. So, walking the fine line between over-immunosuppression and the prevention of medical comorbidities continues to be very challenging for us. Thank you very much.